1/4 video, Ramsay Hunt syndrome, recognizing RHS, Triad and Zoster Sine Herpete, vestibular physician. Welcome to part 1 of our 4-part explainer series. We are pulling directly from the Australian Dizziness Clinics literature review today, and we're looking at why Ramsay Hunt is basically the clinically louder and honestly much more destructive counterpart to Bell's palsy. And as you'll see, catching this early is absolutely crucial for us as vestibular physicians.
Now, think about this. Up to a third of cases never show the classic rash when they first walk in. So how do you actually catch the ones that are just masquerading as Bell's palsy? The stakes here are incredibly high, right? Missing an atypical presentation means you completely miss that very narrow therapeutic window to save your patient's facial and vestibular nerve function.
33%. Literally 1 in 3 of these patients will completely lack that textbook vesicular rash when they first sit down in your clinic. If you're relying purely on dermatological signs, you're going to misdiagnose a massive chunk of your patients. It's a real diagnostic blind spot.
So here's our roadmap for this explainer. First, the loud facial palsy. Then we'll look at the RHS clinical triad, followed by the sequence trap, Zoster Sine Herpete, facial nerve topodiagnosis, and finally, some key takeaways. Let's dive right in.
Section 1. The loud facial palsy.
Now, while the incidence of Ramsay Hunt is only roughly 5 cases per 100,000 people a year, I want you to look at this stark clinical contrast. Dizziness happens in about 31% of Ramsay Hunt cases. Compare that to under 9% in Bell's palsy. This audiovestibular limb, the acute vertigo and hearing loss, is a genuine discriminating feature that is practically screaming for your attention.
Section 2. The RHS clinical triad. The classic presentation rests on 3 main pillars: an acute lower motor neuron facial palsy, severe deep otalgia, and vesicular rash and Hunt's zone. But here's the crucial part. The deep, burning otalgia is often completely disproportionate, and it frequently precedes the physical signs by days. Honestly, an acute facial palsy combined with deep ear pain should immediately ring alarm bells for you. Here we can see the classic dermatological presentation. Notice that erythematous vesicular eruption right there in Hunt's zone. These vesicles love to cluster in the concha and the external auditory canal. Careful inspection of these areas, and that includes the tympanic membrane and palate, is absolutely mandatory in every single acute facial palsy case you evaluate. Physically, you're looking for that flattened nasolabial fold and the drooping oral angle. And because this is a lower motor neuron lesion, the forehead is involved. These patients literally cannot wrinkle their brow or fully close their eye, which, as we know, creates a really dangerous lagophthalmos. Section 3. The sequence trap. I like to call this the rash delay. In roughly 1 in 7 cases, the vesicles actually appear after the onset of facial weakness. So a rash-free palsy on day 1 definitely does not rule out Ramsay Hunt. If you just send them home without antivirals, you're missing the absolute best window for treatment.
Section 4. Zoster Sine Herpete.
All right, Zoster Sine Herpete. This is VZV reactivation causing severe Ramsay Hunt symptoms, but completely lacking the diagnostic rash. And again, this happens in up to 1/3 of cases. The rule of thumb here is simple. A painful facial palsy coupled with vertigo or hearing loss is Zoster Sine Herpete until proven otherwise. You've got to maintain a really low threshold for VZV PCR testing.
Section 5. Facial nerve topodiagnosis.
As you probably know, VZVR reactivation primarily happens right at the geniculate ganglion. But by tracing the nerve's branches distally, the specific clinical deficits tell us exactly how far the inflammation has spread. It's almost like a roadmap. Let's step methodically through this topodiagnosis. Starting at the top, geniculate ganglion involvement gives you that otalgia and the vesicles. Moving down a bit, greater petrosal nerve involvement causes reduced lacrimation and dry eye. Hit the nerve to the stapedius, and bam, you get hyperacusis. Further down, chordotympani involvement causes anterior tongue dysgeusia and a dry mouth. And finally, a purely distal lesion right at the stylomastoid foramen yields an isolated, pure motor facial paralysis. Section 6. Key takeaways. Let's wrap this up with some practice-changing pearls. First, make sure you recognize the full clinical triad, and always remember that deep otalgia often precedes the rash. Second, suspect Zoster Sine Herpete anytime a painful facial palsy pairs up with audiovestibular signs. Test them aggressively. And third, use topodiagnosis to accurately localize the lesion and anticipate any complications. In part 2 of this explainer series, Mechanism and the Audiovestibular Limb, we're going to trace VZV from the geniculate ganglion straight into the spiral and vestibular ganglia, and we'll explain why vertigo can actually show up first. Thank you so much for joining me for this explainer. To explore more topics regarding dizziness, vertigo, and imbalance, and access clinician and patient resource materials just like this review, be sure to visit AustralianDizzinessClinics.com. Please subscribe and leave us a rating.